welcome to JACC Imaging. My name is Tom Marwick and I'm here with Philippe Pibereau from Canada. Welcome, Philippe. Philippe's group have contributed a really important paper in this month's edition of JACC Imaging that relates to the optimal means of assessing TAVI procedures. Philippe, can you tell us more what you've done with this?
Yeah, well, as you know, the Doppler-Echocardiographic evaluation of valve hemodynamic performance is more complex, we know, in prosthetic valve than in native valves. But then, among prosthetic valve, it is even more complex in transcatheter versus surgical prosthesis. So in this study, we did a comprehensive echo evaluation of valve function prior to TAVI, early after, and then 6 months and 1 year. And the main conclusion of this paper is when you measure the effective orifice area of the prosthesis, which is important to identify dysfunction and prosthesis patient mismatch. In transcatheter valve, especially balloon expandable valve, because this was the type of valve that we use in this study, it is preferable to measure the diameter and velocity in the left ventricular outflow tract just underneath the prosthesis stent. Because the reproducibility and accuracy of the measurements are superior compared to if you measure the LVOT diameter inside the stent. Because it is like you have two acceleration in series in transcatheter valve, because the portion of the stent, as opposed to surgical prosthesis, sits in the LVOT. So you have an acceleration at the entrance of the stent and then at the level of the perioprosthetic valve leaflets.
Okay, so the message here is that we should be measuring essentially at the level of the aortic annulus rather than at the base of the stent.
Well, essentially the message is just underneath the stent, so at the entrance of the stent, not necessarily inside the stent. Yep. Now, I think that the results should not be necessarily generalized to all patients, because if the ventricular border of the stent sits relatively low in the LVOT, then, as it may occur especially in balloon expandable valves, it might be preferable to measure inside the stent. But in general, it will be at the entrance, just underneath the stent.
So the bigger picture here, though, really relates to what role these measurements have in assessing patient prosthesis mismatch.
Yeah, in particular, yeah. And interestingly, that was, I think, one of the most important conclusions of this paper, is that in this high-risk population, with a very large proportion of patients with small aortic annulus, 50% of the patients in this study had an aortic annulus measured by TEE at the time of procedure, less than 21 millimeters. So it's much larger proportion than what you have in surgical series. And despite this fact, well, the incidence of moderate mismatch was 20% and severe mismatch 9%. So I think that TAVI may provide an interesting alternative to avoid mismatch or reduce its severity, especially in high-risk patients and especially those with depressed LV function. Because in fact, a few years ago, well, before the TAVI era, we knew that mismatch had an impact on outcome and that ideally you should avoid mismatch, but the surgeon had limited surgical procedure or alternative to avoid a mismatch. And eventually this procedure could increase the operative risk. So with TAVI, we have a procedure that optimizes hemodynamics while eventually minimizing the operative risk.
Okay, so I think that there's a really important message here about the optimal means of assessing the valve area in the implanted patient who has a TAVI procedure. And there may be a bigger picture here that relates to probably a lower risk of patient prosthesis mismatch with these devices than conventional surgery. Thank you very much for being with us today, and I really encourage you to read this important paper.